Well, non-medical switching is a process where patients are switched from one medication to another for a non-medical reason. Usually the reason has to do with money. They'll be stable on a certain medication, and their insurance plan, usually run by a pharmacy benefit manager, will get a contract for a different drug to be preferred. So the patient is, even though the doctor doesn't write the prescription to switch the patient, fiduciary-wise, they can't afford the drug they're still on, and their formulary has changed, so they're forced to take a new medication.
Non-medical switching puts a barrier between the physician-patient relationship. I prefer calling it non-prescriber switching because someone else has made the decision to change a medication, change a treatment plan, other than the physician and the patient. We are at the core of all treatment decisions, and to have someone else, whether it's a bureaucrat or a computer program, step in and say, no, you can't do this particular medicine, even though that is the exact one that we have chosen based on individual history, individual circumstances, past history, and so on, is just an anathema to all of us.
Non-medical switching by insurers or payers can occur in a number of ways. First is the copay card. A number of patients use copay cards to help pay toward the cost of treatment, which we all know can be very expensive. The second way insurers can cause non-medical switching is by changing formularies in mid-year or even at the end of the year so that patients' medicines can be switched by the insurer, not by the physician. And that really is a challenge to the physician-patient relationship.
You become unstable. It disrupts your continuity of care. You can end up in an emergency room or being hospitalized or trying other less efficient treatments, and all of it can exacerbate or flare your disease, bring it out of remission.
On Monday, I see the patient, I treat them, we agree on the treatment that we're going to undergo. And then on Tuesday, I start getting the calls from the insurers or the pharmacies saying, Dr. Dolinar, you can't use that medication. It's not on the formulary, or it's at a high tier or whatever. So I find myself on Monday using my best medical judgment, and on Tuesday being forced to use my second, third, and fourth best medical judgment. When I went to medical school, we were only taught how to use our best medical judgment. So that's frustrating, and I think it's unfortunate for the patient. PBMs have what they call a walk-away rate. And what this is the percent of times that the doctor would walk away from the medication that he was trying to order for the patient. Those rates are literally at 65% or higher, which means 65% of the time when doctors go to order drug XYZ, there are so many hurdles put in place, ultimately the doctor walks away, and only 35% of the patients actually get the medication that the doctor thought was the best medication for them. So that's very frustrating. I don't believe that these insurance plans, the PBMs, the insurers, should be making those medical decisions. Those are medical decisions. That should be made by the doctor and the patient.
We're just asking them to listen to us and listen to our doctor who knows us best, who treats us, who knows our personal medical history, our concomitant drug regimen, and any adverse effects that we've had in the past. They're the best expert to make the decision with us what our treatment should be.